Thanks for asking me to come again. It's always nice to come to the Royal College and speak to an enthusiastic and informed audience. And I'm going to talk to you about several things today, all related to diabetes and chronic kidney disease. Those are my disclosures. And this is going to be the structure of the talk. I'm just going to be slightly cheeky and give you a bit of general background about CKD and where we are with renal function testing, because I think it's useful to be aware of the background so that you can properly interpret patient results. I'm obviously going to talk about diabetic kidney disease. I'll talk about the standard of care for diabetic kidney disease. I'm going to talk about some new treatments that might be on the way. And I'm not going to talk about anything rare, and I'm not going to spend much time talking about guidelines. So this is the current position about kidney disease classification. This was introduced just over 10 years ago, and it was a major change in clinical practice, as you'll probably recall, because it moved kidney function testing away from serum creatinine to estimated glomerular filtration rate. And kidney disease is now classified according to 5 different criteria, grade 1 through 5 of increasing severity, with grade 3 being split into 3A and 3B. And it became clear after this had been introduced as a measure of renal function that actually stage 3 CKD was very broad and it could be split into 2 groups. And rather than make it 6 categories, it was thought better to make it 3A and 3B. Now you can argue about whether that was right, but that's what happened. And this is how the stage of chronic kidney disease relates to the amount of protein a patient has in their urine. So now, renal disease is classified not only according to the eGFR, but also according to the amount of protein the patient has in their urine. And proteinuria is a risk multiplier for adverse events, both in terms of cardiovascular disease and progressive chronic kidney disease in those who might need dialysis. So the more protein you have, the more likely you are to be a hot patient, if you like. And this was the response of the primary care community to the introduction of eGFR testing. And the reason for this was that it suddenly revealed a whole population of patients who had abnormal organ function. And not only that, you were asked by QOF to keep a register of these patients. If you want to get your money, you need to keep a register. And if you're going to keep a register of patients, it's useful to have some kind of idea what you're going to do with that register once you've collected it. So initially, there was quite an adverse response to the introduction of eGFR testing. But actually managing these patients isn't particularly difficult. And it just relies largely on the sorts of routine things that we do at work every single day. In patients who've got kidney disease, blood pressure and stick testing of the urine are central to the management of those patients, not particularly difficult. But what's a little bit more challenging is understanding the basis of the renal function testing we do. So I want to just talk to you for a few minutes about this. So you'll remember from when you were in the phase 1 part of your course at medical school, that you were taught that the gold standard for measuring renal function was to measure the glomerular filtration rate. And that if you wanted to choose a marker to measure glomerular filtration rate, you needed something that was freely filtered, neither secreted nor does this sound familiar if you sort of cast your minds back? Freely filtered, neither secreted nor reabsorbed in the tubule, and then you could measure its clearance in the urine. Now, those markers are not that easy to find, actually, as it happens. And the most common one that we use in research is something called inulin. So inulin fulfills those requirements and can be used to measure glomerular filtration rate. But first of all, if you want to do that, you've got to get your inulin from the root of a chicory plant. Okay, so it's not in the pharmacy, so somebody has to supply that. You've got to bring that patient into a clinical area, you establish an infusion of inulin to steady state, and then you measure its clearance over a period of time in the urine. So not a clinical test that's of great utility for the average clinician. Then there are some isotopic techniques for measuring glomerular filtration rate. So these entail bringing the patient up to the hospital, they're injected with some radioisotope, and then the isotope clearance is measured using a gamma counter, again over a period of time. Patients don't like being injected with radioactivity as a general rule, and they have to hang around a bit in the hospital until they've passed it all, so they don't go out into a public toilet and make it radioactive. So it's quite a lengthy and time-consuming procedure, and again, not something for everyday clinical practice. You'll probably be more familiar with creatinine clearance, and this is still quite commonly used. It's quite commonly used by my colleagues in haematology who guide chemotherapy dosages according to creatinine clearance. But to do this, the patient's got to collect a 24-hour specimen of urine. So how good do you think they are at doing that? And the answer is not very. So, you know, so patients forget. They go to the loo and they think, oh, blast, I forgot to put it in the bottle. So they top it up from the tap. And they guess the amount they might. And we know patients don't do this very well because they bring samples in a big jug to the hospital for analysis, and it has no creatinine in it. And I'm not joking, we have seen that. So patients are not good at doing 24-hour urine collections, and just imagine how it would be for you here today if you had to do that. Not very easy. And even if you can do it, you have to deliver it to a lab and have a blood sample, and so it's a bit unwieldy. And then the serum creatinine. So this is serum creatinine. This is why serum creatinine went out of favour. So if there was a direct relationship between serum creatinine and GFR, such that as your GFR went down, your creatinine went up in proportion, you get a straight line. But you can see that the relationship is much more complicated than that. This is a curvilinear relationship between creatinine and GFR. And what this shows is that you can reduce your GFR down to 40. Okay, so 60% of your GFR is gone, assuming that normal's about 100, and your serum creatinine stays within the normal range. And this is particularly evident for ladies rather than men, but for both. So there are a whole series of patients that sit around the boundary of a creatinine at the upper limit of normal who've got abnormal renal function. And we know this is true because if we take a patient to the operating theatre and take one of their kidneys out to transplant it into their friend or relative, the donor loses 50% of their renal function the minute the surgeon clamps the renal artery, but their serum creatinine remains in the normal range. So that's why creatinine is a lousy marker of renal function. As a surrogate marker of GFR, it's not very good. And when eGFR was introduced, it exposed all of those patients in that sort of area who've got abnormal renal function, but you didn't know it before. So now, when we measure renal function, the sample of blood goes to the laboratory just the same as it ever did. The analyzer analyzes the sample just the same as it ever did, and then the computer attached to the analyzer applies the eGFR equation to the serum creatinine results. And it gives you an estimated glomerular filtration rate. And this is the current equation that is in general use, what's called the CKD epi equation. And it has 4 variables. One variable is the creatinine level, another variable is age, another variable is gender, and another variable is ethnicity. Now, the ethnicity correction isn't automatically applied in the lab because the lab don't know the ethnicity of the patient, but it knows all the other data. So that's where eGFR comes from. So the question that flows from that, after I've proposed to you the reason for changing, how does that relate to true GFR? Is it better than creatinine? And the answer is yes, it is. This is the relationship between estimated GFR and an isotope GFR, true GFR. And you can see that now, actually, we're approximating to a straight line. But it's still not perfect. It still starts to scatter in this sort of area. And in fact, the line starts to tail upwards here. This is the MDRD equation. The CKD epi equation that's used now is a bit better. But nonetheless, it's not perfect, but it is better than serum creatinine. So that's what's happened to renal function testing. And that's what's happened to the rate of primary care testing for laboratory testing in particular. The rate of laboratory testing is skyrocketing, and I'm sure you recognise that from your everyday practice. This was in BMJ earlier this year. The vast majority of these tests are renal function tests in an under-resourced system. So just to exemplify, okay, so this is Mother Teresa of Calcutta, photographed when she was in her 80s. This is Mike Tyson, who you will recall was the baddest man on the planet for a while. He was the most stupendous boxer I've ever seen, actually, and he was 110 kilograms of muscle. And both of these individuals have a serum creatinine of 115. And the question is, does that mean they have equivalent renal function or not? And if they don't, which one's abnormal? So if you apply the EGFR equation to Mother Teresa, she comes out with an EGFR of 42 mils per minute. If you apply it to Mike Tyson, he comes out with a GFR of over 90 mils per minute. And the reason that Mother Teresa has a high creatinine is that she's not filtering creatinine. The reason he's got a high creatinine is that he's making tons of it because it's coming out of his muscles. So the thing to remember about EGFR testing is that for some patients it's not valid. So for patients who have an amputation, they lose muscle, EGFR becomes an invalid test. It's not valid in pregnancy because the volume of distribution of creatinine is different. It's not valid in children. It's only validated in adults. So what happens to these people? Why is it important to understand their chronic kidney disease? And the answer is because they tend to die early. And the majority of patients with chronic kidney disease will die of cardiovascular disease before they go anywhere near a dialysis machine. And the death rates are really quite high. These are 5-year mortality rates. For stage 3 CKD, nearly 25% mortality in 5 years. Now, that's not just to say that it's necessarily driven by the CKD alone, because they tend to have comorbidities, but it does mark out a high-risk population. And if they've got risk factors, they should be managed as best you can. So the question is, at what point in their CKD does this cardiovascular risk increase develop? And the answer is early. There's a break point in the risk for mortality with a GFR of around 75. So the increased risk of cardiovascular disease develops early in the course of CKD. And it gets worse as it progresses. Now, we see lots of patients in our clinics, and you'll have them in your practices, who are developing progressive renal impairment. Some of these patients will eventually need dialysis. Now, the thing to remember is that not everybody progresses at the same rate. Some people progress quickly, some people progress more slowly. Sometimes, if they have an intercurrent illness, like a bout of sepsis, then this line will steepen for a while, or may stay steeper. So the thing is, if you have somebody who's progressing quickly, if you can shift their rate of progression, you might give them years off dialysis. So if you treat their blood pressure, or if you put them on an antiproteinuric agent like an ACE inhibitor, you might shift their line to the right. And it might not stop the decline in their kidney function, but it might slow it. And if you do it early, you might give them 10 years free of dialysis one day. So that's worth doing. This is a question I'm often asked, and people like John and I take this for granted. But when do people start dialysis? And the answer is very late in their disease. Most people start on dialysis when they've got a GFR between 7 and 8. So that's way down the line for most of the patients you've got in your practice. It's an important piece of information, though, to kind of perspectivise all of this. And this is what happens when you're on dialysis. The details of the slide don't matter. I'll tell you what the important points are. This is data from the European Renal Registry. So if you're, for example, let's assume that the average age in this room is 40 years of age. If you're 40 in Europe now, you can expect to live roughly another 42 years. It's a bit different for men and women, but roughly. So life expectancy from 40 is roughly the same again, another 40 odd years. If you're 40 on dialysis, your life expectancy is 9 years. If you're 40 with a kidney transplant, your life expectancy is about 20 to 25 years. So again, this is some information that probably is worthwhile knowing when we're talking about patients who've got progressive kidney disease who might one day require this treatment. And this restriction in life expectancy doesn't just start the day you go onto dialysis, it evolves over the course of your CKD. So, what is the point of knowing about patients who've got chronic kidney disease? Why keep them on a register? Because you can address the cardiovascular risk factors that they do have that might stop them from dying. You might be able to slow the progression of their kidney disease in those who are destined to need dialysis. And you don't want to do them any harm. And we see lots of patients who are harmed by medicines. So you might want to, for instance, program into an electronic medical record system an inability to prescribe a non-steroidal to somebody who's on your CKD register. So there are some relatively straightforward things that you can do to protect patients from inadvertent prescribing. These are the chronic kidney disease guidelines, which I won't labour. And this is a fairly cynical publication, I think, that came out in BMJ earlier this year. Are guidelines for monitoring chronic disease in primary care evidence-based? Guess what the answer is? Well, the answer is partly, actually. And like any guidance, some of it is based on really quite robust evidence, and some of it is based on opinion and experience. And the CKD guidelines were picked out for analysis in this paper, and some of it is not very well evidenced, but I would suggest to you that it is based on at least educated advice. Okay, so what about diabetes? So about 40% of patients with diabetes will get some evidence of chronic kidney disease. Over the globe, diabetes is the commonest cause of CKD now. Most patients that I see now with diabetes and kidney disease don't conform to the classical diabetic nephropathy paradigm, where they hyperfilter at the beginning, then they get microalbuminuria, then it gets higher still, and at the same time their GFR starts to come down. That's the classic diabetic nephropathy, and we still see that. But actually, most patients don't conform to that now. Many don't have any proteinuria at all. And they have chronic kidney disease, which is more in a setting of other cardiovascular morbidity, with type 2, commonly diabetes. And chronic kidney disease is a risk multiplier for everything that's bad about diabetes. So all of the complications that patients with diabetes get will get it worse if they've got CKD. And these are survival rates for patients on dialysis, again, adjusted for their primary disease. And the line at the bottom, the worst survival is diabetes. 30% are dead after 2 years. It's a very bad disease. Diabetic kidney disease on dialysis is very bad. So what are your treatment options in primary care for patients with chronic kidney disease and diabetes? Glucose control, blood pressure, ACE inhibitors or other modifiers of the renin-angiotensin system, and dyslipidemia. And I want to illustrate those with a typical case history. This is very typical of the sort of patients that get referred to our clinics. 78-year-old man, he's had type 2 diabetes for many years. He's got a GFR of 30, and if you look back in your practice records, it seems to be going down. He's had a previous stroke, good recovery. His blood pressure is 146/78. He's got a cholesterol of 4. He's got some protein in his urine. He's got an HbA1c of 7.8%, and he's taking aspirin and ramipril and a beta blocker and metformin. So what are your options? You must see patients like this all the time. So let me just talk you through what I think your options are in terms of treating that particular patient. So, would you stop the ramipril? Would you add... Well, I'm going to answer the question for you. You can shout out now if you like. I was going to go through the evidence, but we can stop here and just... No, but okay, but this is fine. So would you stop the ramipril? Okay. Would you add something else to the ramipril if reducing proteinuria is important? Would you add an angiotensin receptor blocker to that? Would you stop the metformin? Would you intensify the diabetic control? Would you intensify the blood pressure control? Would you add a statin? And would you refer to nephrology for dialysis planning? No, is the wrong answer. So let me just take you through those options, and I'll give you my views on this. So this is ACE inhibitors in diabetes. This is some data from 1993. I can't tell you how much this changed practice. This was the first real clinical evidence that using ACE inhibitors in patients with diabetes protected their kidney function. It was published in the New England Journal of Medicine, and it shows quite clear that captopril, which was the ACE inhibitor du jour at that time, prevents patients requiring dialysis or needing a kidney transplant or dying. This absolutely revolutionised the way that we use these agents in patients with kidney disease, because before we thought they were contraindicated. And now we give ACE inhibitors to virtually everybody who's got proteinuria. This was a terribly influential, game-changing paper. And there have been dozens of papers since then that show that this is true, that different ACE inhibitors are broadly comparable, that ACE inhibitors and ARBs are broadly comparable, and that it applies to type 1 and to type 2 diabetes. So there you go. That's the reason that we're so... we sort of push a lot of ACE inhibitor usage. Sadly, this was one of the last major advances in chronic kidney disease until quite recently, and we'll come on to that in a minute. But this was a real game changer. So that's ACE inhibitors. What about combining it? If reducing proteinuria is important, which it is, why not give the patients two things to do that? Why not combine the ACE inhibitor and the ALB together? And if you do that, it does reduce proteinuria further, but sadly, it increases the risk of acute kidney injury, and it increases the risk of hyperkalemia and hospitalizations. So the combination of two agents is not recommended. One, yes, two, no. Metformin. Now, we find ourselves in a difficult place with metformin because it's a good drug. Patients find it easy to take. It's dead cheap. But we have this issue with it causing lactic acidosis. And for that reason, it's generally recommended that metformin should be stopped in patients with CKD, with a GFR of less than 35 is the rule of thumb we use. I have to say that this evidence, this statement, is not very strong. And there are some very strong counter-arguments about metformin actually being quite safe. I've seen hundreds of patients with lactic acidosis. I can't think of a single one where you could easily attribute it to metformin. Because these patients, when they come into hospital with lactic acidosis, are usually sick, they've got infections, they've got all sorts of things. So to blame the metformin, I think, is a bit difficult. But we are in a position now where it's always advised that metformin should be stopped. So I think it places the prescriber in a difficult spot. So what about intensifying treatment for blood pressure? There was a paper published they called the Accord study recently, which showed that if you treat diabetic patients with type 2 diabetes to an intensified target of 120 versus 135 millimeters of mercury systolic, they get more complications, and the effect on outcomes is modest, if not absent. Now, this was in just general type 2 diabetes, not focused on CKD, but what I would say to you is that intensifying the blood pressure control has risks. What about glycemic control? It's very well recognised that if you treat diabetic patients early in their disease with an intensified regime that really gets their glycemic control much better, then that reduces their vascular complications way down the line. And we know that from big studies that were performed 20, 25 years ago and have been followed up. And even we know that even when years later their diabetic control gets bad again, they're still protected from that early phase when their glycemic control was good, what's called metabolic memory. But what's less clear, actually, is if you take them further down the line, when they've got their complication, particularly when they've got their CKD, and then you try and start to bring their diabetic control, really intensify it, that doesn't seem to be so beneficial. So there may be some reasons for trying to get their diabetic control better, but it probably won't protect their kidneys. And what's even worse is that CKD patients are particularly at risk of hypoglycemia. So these are patients, these are reference patients with no CKD and no diabetes. These are patients with CKD and no diabetes. So if you just give patients CKD, they will get hypoglycemic. And when we see them in hospital when they're sick, hypoglycemia in sick CKD patients can be really, really challenging. So my point being, if you're going to intensify diabetic control in CKD patients, they're already at risk of hypoglycemia, so you need to be careful. So what about statins? This data was published in The Lancet in 2011. Now, I go to a lot of conferences, and I've only been to one conference where the audience has burst into spontaneous cheering and applause at the result of a study. And it's amazing what people have in their lives, I suppose. But this, this was the result of the SHARP study that was published in The Lancet by our colleagues from Oxford, which shows absolutely clearly that reducing cholesterol using statins in these patients protects them against cardiovascular outcomes. It's roughly a 25% reduction in cardiovascular events with statins and ezetimibe. Very clear. Very, very clear. And this is really, I said earlier about the sort of dearth of outcome studies in nephropathy, in nephrology since 1993. This is one of the positive studies, and it's very important. So, just to go back, these are our options again. Stop the ramipril, and I think the groundswell of opinion in the room was, no, you wouldn't do that, and I agree. Would you add an ARB to ramipril? No, I don't think you would. Would you stop the metformin? I think you probably would. There might be some wiggle room sort of round about a GFR of 30 where you can have a conversation with the patient. But if you ended up in front of the judge on that, I think you'd be quite difficult if you continued it. Would you intensify diabetic control for CKD? No, I don't think you would at this stage. Would you intensify blood pressure control? Well, I think you would from this particular patient whose blood pressure was 148 or something systolic, and I think you'd aim for a systolic blood pressure of less than 140. Would you add a statin? Yes, you definitely would. And would you plan for dialysis and refer him to my clinic? No, thank you. Not at this stage. But actually, I mean, the thing is about these referrals, this is just a little bugbear of mine. We don't need to see that patient to give that advice. There is no robust way in our system, I don't think, that allows us to interact, to have some informal advice about a patient like this. It has to go through choosing book or some kind of letter. And we need a simplified system whereby you can dip into secondary care services for advice, and we don't need to bring that 70 or 80-year-old patient up to a hospital clinic. And I think we need to think about how we can manage demand that way. Because it's quite legitimate, I think, for me to be asked those questions. I don't think it's legitimate for that patient to have to come to clinic for the answer. So, what might change? I've just got a couple of extra things to show you. SGLT2 inhibitors. Now, these started off as being a sort of niche addition to the armamentarium for the treatment of glycemia in type 2 diabetes, and they're mutating into a monster. And the outcome studies for SGLT2 inhibitors show really profound cardiovascular protection in patients with diabetes, and similarly profound protection against diabetic kidney disease. And again, if we look at the studies, that patients on the SGLT2 inhibitors, their renal function is maintained, whereas those who don't get it are losing their renal function. And these are in diabetes studies. Actually, it seems as though the protective effects of SGLT2 inhibitors might be more generalizable beyond type 2 diabetes. And there are some studies now using SGLT2s in patients with CKD other than diabetic. So I think we'll find that these may revolutionize our treatment of diabetic complications, just the way that ACE inhibitors did 25 years ago. So hyperkalemia. Do any of you get troubled by hyperkalemia in terms of a result getting phoned through to your practice at 6 o'clock in the evening and you think, oh my God, now what? And this happens all the time. And these patients, for all these reasons, get sent to the emergency department at night and it's busy and they're there for hours while somebody rechecks their potassium level. And it's certainly true that diabetes that is associated with hyperkalemia for a whole range of reasons that I won't go into. But help may be at hand. So there are some new potassium binding resins which can be taken orally, which bind potassium in the gut and obviously stop it being reabsorbed. And these have been shown to be effective in reducing potassium levels in patients with CKD. There have been oral treatments for hyperkalemia in the past, but they've tended to cause gut necrosis, so we can't use them in the long term. But these may be a real alternative and have just been licensed. Their license is quite restrictive at the moment, and their license is around making space for some of these saving medications that would otherwise cause threatening hyperkalemia. So in patients with CKD or in patients with heart failure, for instance, if they really need to stay on their ACE inhibitor but their potassium's too high, this might be the answer. My guess is that there will be some mission creep with these agents as time goes by. But again, I think some hope on the horizon. So what's my take-home message? So CKD is definitely common. It's common in diabetes, but it's common in the general population. It should really be considered as part of a cardiovascular profile, and the management of CKD in the majority of patients with diabetes should be part of their cardiovascular risk management. Standard of care can easily be built into the management of diabetes, and I think some new treatments are on the way that might change things in the near future. So on that, I'll leave it. Thank you very much.